Welcome. In my presentation, I would like to talk about the availability of structured data elements in electronic health records for the purpose of patient recruitment in clinical trials. But before I jump right into the topic, I would like to introduce myself and say a few words about the background of this work. My name is Albert Fass, and I work in the University Medicine Greifswald. It is one of 10 German university hospitals collaborating in the MIRACOM consortium, which in turn is one of the 4 German consortia, the others named DFuture, HIMED and Smith, which belong to the German Medical Informatics Initiative funded by the Federal Ministry of Education and Research, aiming to boost the integration of health data from patient care and medical research. For those who are a little into geography, Greifswald is a small city located on the northeastern tip of Germany. The presented work was done in context of the Use Case 1 work group of MIRACOM titled Alerting in Care, and one of its foci is to assist the process of patient recruitment in clinical trials. This process can often be considered as a, if not the bottleneck in clinical research, since it can be a time-consuming and lengthy task to find a sufficiently large number of participants manually. In some cases, this can even lead to the termination of trials. This is when the use of routine care medical data in research, the so-called secondary use of electronic health records, comes into play, as it is a promising approach to speed up patient recruitment. But for this purpose, some requirements have to be met by electronic health record data. First, the data elements which are relevant, what means they are queried as a trial's eligibility criteria, have to be present in the electronic health record in a good quality. I will describe what that means shortly. Second, to automatically generate proposals about participants, these data elements have to be present in a machine-usable form. In this work, I will focus on completeness as the data quality dimension. Now, I want to give a brief overview about the methods and then present and discuss the result of the analysis on 436 anonymized patient records in the 10 university hospitals within the MIRACOM consortium. Let's start with the preparations. In order to identify relevant data elements among the eligibility criteria, the prevalence of these criteria in 50 clinical trials has been determined in previous work. Then, the documentation quality of the most frequent data elements derived from these trials has been assessed by evaluating the electronic health records of a sample of cases at each site's 5 most relevant departments if we look at the number of visits. The case selection criteria included that the cases had to be already closed. Then, they had to be acquired in context of an inpatient stay from 3 to 15 days in 2018. The sample was restricted to a range of primary diagnoses, namely chapters C, E, G, or J from ICD-10 German modification. The randomization was balanced with respect to diagnosis chapter occurrence. By this, approximately 45 cases from each site were taken into account, resulting in the evaluation of 436 electronic health records. For each data element, a set of meta-information, for example, documentation quality, date of first occurrence, date of first and last documentation, and so on, was acquired to allow an insight into the documentation process in routine care. In addition, for some data elements, the meta-information were taken for different patient status, namely medical history, admission, stay, and discharge. As I have mentioned, when it comes to data quality, I would like to focus on completeness, or to be more precise, the availability or proportion of present data elements in the health records. I would like to answer also the question which fraction of the available data elements is documented in a machine-usable form. Although the data acquisition process also included steps for data consolidation, the data analysis revealed that the low-effort approach in the data extraction spreadsheets allowed certain freedoms, which led to inconsistent entries across sites. This hindered us to determine the availability of a given data element directly. Instead, we chose the following indirect approach. The availability of a data element was determined by analyzing the meta-information provided with it. If, for a given case, for example for the data element blood pressure, the date of first occurrence, date of first documentation, and date of last documentation was denoted, we can assume that this data element was recorded in the case. If, on the other hand, none of the date meta-information is denoted, we assume that the data element was not recorded. If some of the three meta-information are missing, we conclude that there might be a lack of documentation, but still we can assume that the data element was recorded. A special treatment was applied if only the date of first occurrence was denoted, as it turned out that in some electronic health records it can originate from an earlier inpatient stay. That's why the data element was ignored if its date of first occurrence was more than 2 weeks before the beginning of stay. The other important property is whether a data element is available in a machine usable, also called structured form, or not. Structure in this context means that the data element of interest is stored in a form well suited for direct processing, in contrast to a form which requires a number of steps before the data element can be automatically processed. For example, a PDF scan of the medication plan would require the steps character recognition, text analysis, and probably mapping to ATC codes before automatic processing. Therefore, it would be considered as unstructured data. The data quality assessment form allowed to classify the data elements with respect to their structure into structured, unstructured, both structured and not, as well as unknown. If the data element was labeled structured or both, it was counted as structured. If it was labeled unstructured or unknown, or no entry was provided, although it was present in the case, it was counted as unstructured. Let's get to the results. The diagram shows the relevance of the data element groups as eligibility criterion versus their availability in electronic health records. Rather structured data element groups are shown in dark, while rather unstructured element groups are shown in light blue. The vertical arrangement in this diagram corresponds to the relevance of the data groups as eligibility criterion. If we take, for example, the data elements date of birth and gender from data group demographics, which are ubiquitous eligibility criteria, we can see that they are, except for rare cases, present in almost all health records in a structured form. The data group of diagnosis, consisting of data elements for admission diagnosis, primary diagnosis, secondary diagnosis, and non-coded secondary diagnosis, is quite similar to the demographics group, though showing a wider distribution in the range of availability. This is due to the fact that the non-coded secondary diagnosis is sometimes omitted and thus contributes to a lower overall degree of availability in this group. But before I come to the data element groups procedures and medication, which show a wide distribution and require a closer look, I want to give some details on the lab findings data group. So, this group is seldomly chosen as eligibility criteria, but the data elements are typically recorded at all sites in a structured form. This is not really surprising, as the data elements are often directly fed into the electronic health records without manual interaction. The fraction of present data elements differs from site to site because different sites seem to have slightly different compositions of lab parameters utilized in routine care, and so the availability shown here depends on how well the selection of the 5 lab parameters in the assessment is covered at each site. But now, let's take a closer look on the procedures and medication data group. Both of these groups show a wide distribution in terms of availability. Basically, Both data groups contain data elements for coded and non-coded procedures or medication. And the medication data group contains also data elements about the dosage and the end date of medication. For clarity, I would like to focus on the coded versus non-coded data elements. In addition, I want to break down the availability by different patient status. These are medical history and inpatient stay with procedures and extended by admission and discharge within the medication data group. In the diagram, it is shown for the procedures data group. The availability of the data elements indicate that on average an emphasis in the documentation is laid on coded procedures during patient stay. Though the non-coded procedures during patient stay are less complete, still more information is provided compared to coded procedures in medical history. One could summarize that the focus shifts from non-coded to coded documentation when going from medical history to inpatient stay. This effect is most likely forced by regulations, as coded procedure documentation during inpatient stay is billing relevant. In some respects, the behavior of the medication data group is similar to the procedures data group. Probably less pronounced but still detectable, the availability in the documentation of coded medication during inpatient stay is above the availability during other stages. But for every stage, the availability of the documentation of coded medication lags far behind that of non-coded medication. It is worth mentioning that within this data group, few sites excel by heavily using coded medication in the documentation, while others stick to non-coded documentation. So, to summarize, this has been the first data quality assessment in the Miracum Use Case 1 work group, based on data elements derived from 50 clinical trials. We have found the lab findings, the diagnosis and the demographics data groups to be available in 73 to 88% in our sample, while medication and procedure data group were available in only 44% of the 436 cases. The results we have found are in good agreement with the results of comparable studies performed by Dutz et al. And Köpke et al. Minor differences have been found in the lab findings data group, but this is most likely due to the fact that technical progress has led to a better integration of laboratory systems with electronic health records. In the meantime, then the documentation of medication in routine care turned out to be a promising parameter for improvement. In the near future, it is planned to perform a second data quality assessment to monitor the development within Miracum. And with this, I would like to come to the end of my presentation and thank you for your attention.